Okay. Welcome, SLP215. Okay, module 4. So a couple things just I want to review from last week to make sure everybody's clear. Okay, aspiration. Aspiration is food or liquid, something entering the lungs, I should say. So anything that's entering the lungs that shouldn't be there. So foreign substance entering the lungs, that's aspiration. Now, aspiration pneumonia is caused from the bacteria that entered from aspiration. So the food or drink that go into the lungs don't necessarily cause pneumonia. It's the bacteria that's on that. So if you're having foreign things enter into your lungs, you are likely to get sick or can get sick or put yourself susceptible to being sick. So aspiration pneumonia is what happens. Aspiration itself isn't the illness. So I just want to make that clarification. A couple people miss that, but I see why that's easy to confuse. Then the other piece too is that your vocal folds, the primary purpose isn't just for speaking, it's to protect your airway. So if you do have anything on those vocal folds, whether that be a polyp, a cyst, a nodule or something, that can put your airway at risk. So the purpose is we close them to keep things out of the trachea. And remember, they sit above the trachea. So, you know, our windpipe or trachea is there. That's where the air comes from for our voice. So just remember that our vocal cords, our vocal folds sit on top of the trachea, and they come together to protect our airway. Now, and then aspiration is just things entering our airway, food, drink, and aspiration pneumonia is the illness that happens from that happening. So the other piece too, just from other key piece of info. So when we're working with clients, a lot of times too, we review just good oral hygiene. So like my brother, he's on a feeding tube. He aspirates pretty extensively. He has cerebral palsy. He's much older than myself, and he was aspirating, and he wasn't getting enough intake anyway. So he's on a feeding tube, but he wants to eat. He's very motivated to eat, and he's had speech on and off to help with feeding. And he's limited, but I review with him. My mom does. You got to take good oral hygiene. So before he eats, really working on the bacteria in the mouth, because the food itself isn't going to make you sick. It's the bacteria usually in our mouth that's on the food that does. So just if he wants to eat, we know he's going to aspirate, just really working on that oral hygiene ahead of time, just to try to reduce the risk of getting sick. So again, there's a lot of other ethical issues, but my mom and I talked extensively about, but he's going to eat whether it's approved or not. So we got to work on at least trying to keep him as safe as possible. Okay, so resonance. So we talked about voice. Now resonance is a little bit different. So this is when we're talking about the nasality, the resonance. So you know how when you sound when you have a cold. So if you have a cold, you're usually hyponasal. Especially if your nose and sinuses are all blocked up and you can kind of hear it a little bit different. And then there's also hypernasality. So all the sounds are coming out your nose. So review from 214, what sounds are nasal sounds? So M, N, and ING, the ing. So those are our nasal sounds. There are some vowels that can be nasalized, especially in Indiana where I went to school. They can kind of, if you have a nasal sound, vowels can kind of be nasalized a little bit. Oh gosh, I can see your face. The only thing, okay, Fran Drescher. So she's one that's got a lot of hypernasality. She's got a weird quality to her voice, and that's that resonance piece for her. I'm sure there's others. That was just the one I could think of off the top of my head. But Oh wait, hold on. I don't want to do this one first. So resonance disorders. Oh, sorry. I don't know why I do that sometimes. I clicked the wrong next. So just a quick review. So what we're seeing too is that velopharyngeal port. So it closes off or it opens. So if there's some insufficiency there, we usually have problems with resonance in the nasality. So it's the balance. Resonance technically is the balance of sound vibration in the oral, nasal, and pharyngeal spaces. Boy, I got my Invisalign. I can't talk either. Resonance is the balance of sound vibration in the oral, nasal, and pharyngeal spaces during speech. So in English, all sounds are resonated through the mouth with the exception of M, N, and ing. Normal function of the velopharyngeal port is required for good resonance. So sometimes people have velopharyngeal port difficulties, which is why the nasality is off. And the velopharyngeal port elevates towards the back wall of the pharynx and sealing off the airflow through the nasal cavity. So what we do know, other changes to resonance can be caused by obstruction, malformation, or malfunction. So obstruction is kind of when we've got, our swollen tonsils, adenoids. We've got, stuffed up nose. So that's like what we call an obstruction, something that's obstructing its function or the airflow. Then malfunction means, something's not working quite right. Or malformation. So a lot of times resonance is related to malformation. Some of the key disorders, I think right off the top of my head, is cleft palate. A cleft in your palate usually causes some kind of issue. Also too, sometimes when we've got some tonsils and adenoid problems, there's some other, not just obstruction, but malformation. Oh gosh, I did it again. So sorry. So this kind of gives you some of what's going on during breathing, during speech. So velopharyngeal dysfunction, what's it caused by? Insufficiency, so the structural defect that does not allow for proper contact. So there's something wrong with the structure, which is why they don't have proper contact. Like not just an obstruction, a real problem with the velopharyngeal port. And sometimes when we look at some kind of craniofacial anomaly that they've repaired or fixed, sometimes that port is just not big enough. So incompetence, so physiological weakness, paralysis of the velum that does not allow for proper contact, mislearning. So there's sometimes often articulation errors caused by just mistiming or misuse of the velopharyngeal port. Velocardiofacial syndrome is a big one. There's lots of some distinctive facial features, resonance, with minor heart defects. So definitely some syndromes that cause craniofacial difficulties that kind of can come into play here. Oh boy, gosh darn it. I apologize. I must be tired today.
Can I ask a quick question?
Yeah, go ahead.
How common is that velopharyngeal, I can't remember the rest, sorry.
Yeah, no, the velocardiofacial, VCFS. I've had several kids. I'd have to look up the prevalence. I think it's a more common one. Like I said, it's probably been a couple years since I've had one. And you know what I want to say too is with the velocardio, I don't feel like it's well diagnosed. So usually sometimes if there's a heart issue, it's minor. They're supposed to be, I don't know, I feel like Arizona, I'm just going to throw Arizona on the bus. I don't feel like we do a good job of genetic testing. And then I also throw insurance companies, because a lot of times that isn't covered and it's extremely expensive. So I don't feel like we do good screenings sometimes for some of those things. In fact, I have one kid right now on my caseload. I suspect he has this. There's all kinds of things going on that lead me to suspect that. And, you know, I'm not sure he even goes to a regular dentist. I'm hoping he gets to a dentist and a dentist says something to him, to his parents. But I think it's more common than I think it maybe is a little bit underdiagnosed if they don't have some of the palate stuff that's real severe. So common causes of velopharyngeal port dysfunction are cleft palate, apraxia of speech, submucosous cleft. Gosh, I cannot talk. Wow. That's pretty also, I would say, underdiagnosed. It usually doesn't come up till a little bit later when child's, you know, starting going to the dentist. I think that's when it comes up. Enlarged adenoids, and then other neurological disorders. So what we see is there's something neurological going on. I don't know if I talked in this class. I had a student who had ALS, very young, never seen it this young. In fact, you know, very, very rare case. And her residence started to get weird. I remember that. I've known this, so she was what, a sophomore in high school? And I knew her since a first grader. And she had some challenges, and I thought maybe seizures were going on because I saw some of these neurological signs. And definitely I noticed changes with her resonance and her voice. Lots of different little signs that showed some neurological issues that, you know, I think her mom definitely explored. I thought the parent did a good job trying to get answers. It just was one of those things that was hard to diagnose because of her age. So if you look at kind of the normal palate, left unilateral cleft, and then bilateral. So sometimes you'll hear unilateral where it's just on one side, or bilateral. So sometimes they just have a cleft lip. So there's just a cleft in the lip, not in the palate. Cleft in the lip is very, I mean, that's way minor compared to bilateral. That's more of a challenge. And then a bigger cleft. So there's a lot more repair to be done there versus a unilateral. So definitely you see some differences in the severity of the cleft palate. That's something we also have to consider. Bifid uvula. So looking in kids' mouths, what's funny is I have this. I have a bifid uvula. I don't have a submucosal cleft, but I always have checked it out now a couple of times to make sure that somebody didn't miss that. But that's a telltale sign, because usually it comes together and fuses into one, and then when it doesn't, something's going on that should alert us. So you ever look in a kid's mouth, you see that, please alert your supervisor. You would hope. But I will tell you, we've had times where we've tried to do an oral motor exam and it didn't really go well, or they didn't cooperate or whatever. So sometimes you working with the kid, you finally get somewhere, or you have them open their mouth, you're working on K&G, whatever it is, and you notice, please alert your supervisor to make sure that they know that that's going on. So you can see kind of, if you Google the submucosal cleft, you'll see some good pictures, but this is a good picture of a bifid uvula. Adenoids, allergies. So another big problem here, enlarged adenoids from allergies, whatever reason. Definitely this can cause a lot of issues with residents. Okay, and hopefully you guys all know the difference between normal tonsils and large tonsils. Tonsils, adenoids do make a difference in speech. So something we all need to be aware of. Or someone's had their tonsils and adenoids out and now they kind of have some dysfunction. It's usually just some simple activities to get them up and going. impacts to articulation. So if you have nasal air emission, you're losing those abilities to produce what we call like our stop consonants. So a stop consonant, here's speech science 101. So a stop consonant, or a plosive, stop plosives. I'm not sure which, again, here we go, speech with a million different ways we say things, million names for the same thing. So I don't know what, I think Mr. Meeks teaches 214. So I say stop consonant, stop plosive, but what that is, it means it's a stoppage of air. So a p, a b, a k, a g. Those are all made because we stop the air. When you have nasal air emission, you're not stopping the air, so they lose the power, so they're harder to say. So a lot of times we hear nasal air emission with our hard of hearing clients. So clients who are hard of hearing a lot of times can't hear those differences in resonance. Cul-de-sac resonance too, muffled resonance quality often due to enlarged tonsils. So I can hear it, I can tell you right away. I can hear it in myself. I know right away if I might have strep throat. Strep throat's another one that really does a number with my voice. I can hear it right away. I could hear it with my oldest for sure. And then the hypernasality is too much air coming out, but the nasal air emission is a little bit harder. I think that it's a little more subtle, but it definitely can impact intelligibility. And then abnormal dentition and occlusion can definitely impact articulation. So I have a one right now, and he's, like I said, I think he actually has maybe this velocardial facial syndrome. His resonance is horrendous. His speech production is absolutely, inside of his mouth is not good. And, his teeth are they're every which way. They're definitely, there's a lot going on in there. And I remember, I've been trying to talk to his mom. She's frustrated. He's not making progress. I keep talking to her about, have you talked to an ear, nose, and throat specialist? About ready to put it on the school's dime in this case. But, I'm waiting for her. I'm like, have you been to the dentist? No, he's been fine. We haven't been to the dentist. I'm like, oh my goodness, he needs to go to the dentist, because I'm waiting for the dentist to say something. He's young. Mom's not from, she's different cultural too, so they have some different things there. So I'm trying to be, respectful of that. But abnormal dentition can absolutely impact articulation. And also you got tonsils and adenoids going. That affects your palate, that affects the growth. There's a lot of things that play, especially in our developing or younger clients that are developing. And when you've got some challenges there, that can definitely impact things long-term and short-term. And a lot of times that also can lead to mislearning of sounds, or kind of getting some dysfunctional habits. That's what I call it. So other things too. So the other big thing that we have to remember is, because I'm having this problem with actually 2 of my clients right now. Enlarged tonsils and adenoids, we have poor resonance, we have poor airflow. So definitely, and we definitely see this with clients, cerebral palsy is another one that comes up a lot where I see this. If you have decreased airflow or dysfunctional airflow, or air is not flowing correctly, you will have typically a decreased MLU. You need more air. You're not saying longer sentences. Definitely can have decreased intelligibility. So all of these things that we see related to resonance can impact a client in different ways. So one person can have a little bit of nasal air emission and not affect them like it does somebody else. So definitely some key pieces there. You're working our tick, you're like, well, they're producing it, they're saying it right, but something's a little off. Definitely have your supervisor come and listen. Or we'll notice right away, hey, so-and-so got their tonsils out. Everything's changed. Come on down. Let's work this out. So definitely, you have a client has their tonsils and adenoids out, please let your supervisor know. Other thing too, the other thing I want to say, a lot of times too, things related to asthma, tonsils, adenoids, increased strep. Then a lot of times too, their overall output just of like running physical activity can be decreased. And then we've got sleep apnea and all kinds of other things. So then that affects behavior, that affects your cognitive skills. So definitely I think one of the most underdiagnosed, undertreated, underaddressed issues in our speech and language realm is tonsils and adenoids. Definitely in tubes. Oh my gosh. Get the tubes, get the tonsils and adenoids out. I understand requires surgery, all of the above, and that's not always fun for parents to want to put their child through, but I think it definitely impacts, not to mention the sleep. So a lot of times you got enlarged tonsil and adenoids, they're getting deficient sleep and disrupted sleep, disordered speech, or disordered sleep and then distorted speech, and then we just got a bad loop going all the way around. Then too, like I can see, got a couple kids, I call it, you know, the tonsil and adenoid face. It definitely impacts facial development too. So there's lots of good videos of hyponasality, hypernasality. So is everyone clear on what resonance is? So it's related to that airflow and the way the air kind of modulates within your oral cavity. So looking for how do we treat it? That will be, there are activities to help with resonance. Your supervisor will usually direct you, but just kind of be aware of some of the things. So let me go to treatment of resonance disorders. So there's a couple key pieces. So clefts are going to be repaired by a surgeon. We're going to usually deal with the aftermath of that. And a lot of times our clients with cleft lips, cleft palates have multiple surgeries. So they don't just usually have one. Well, cleft lip, usually one. But cleft palate, it's usually more than one. So usually for velopharyngeal, it's an insufficiency. What I want to say is it can be effective. Speech therapy alone can be effective if it's mild. But really, truly, a lot of times surgical intervention is required. So a lot of times we're not going to fix it. We may make it better. We may teach them a compensatory skill, but a lot of times it's going to be surgery for our client with this. And there's some even better ones. I know that's improving each year. Yeah, so like I said, talk about the different surgeries. So speech therapy, no matter how much we do, we cannot change structure or malformation. So this is where sometimes we might try something. We, especially in school-based or clinic-based, we might not be able to scope, do a nasolaryngoscope, things like that. A lot of times we'll try therapy, see if it helps, and if it doesn't, we usually refer back to the surgeon, the ear, nose, and throat specialist. So therapy can change insufficiency and mislearning. We cannot change a malformation, no matter how much we want to. So when should we do therapy? It's when nasal emission's mild, and then sometimes we get other distorted articulation errors, or if the nasality is like phoneme specific, so they're always nasal on a certain sound or two. So a couple different things. So if you look at this, obviously auditory feedback, we teach them to hear the differences. What we noticed is a lot of times with our clients with maybe some hearing impaired issues, they can't hear the difference. So it's hard. We've got to work on some other tactile and visual feedback. So some ear, nose, and throat speech therapists with ear, nose, and throat often in their offices have some great actual visual feedback, biofeedback to work on this specifically. I've not had this ever in an outpatient or school-based, but there are some great ones, or we'll send them down to Midwestern or ASU. They usually have those at the university clinics. So like an air paddle, there are some little things that we do to show, like maybe put a mirror so they can see the breath coming out. Do some things with cotton balls, things like that, to kind of teach about airflow. So sometimes we have to work on the concept of the airflow, and then we have to then show them what we're talking about when they do certain sounds. So a lot of times we kind of have to give them some of that visual so they can start to feel the difference there. So definitely some things we do too is, the Young technique. We practice vowel sounds. A lot of times too, I want them looking in their mouth, have more awareness about where their tongue goes, move in that velar pharyngeal port, kind of do those differences between like M and P or M and B. So definitely hearing some of those, what I would call, nasality pairs, nasal and the non-nasal sounds, for them to really know the difference. So here's some tactile cul-de-sac method. Definitely we do talk with your nose pinched versus not, kind of hearing those differences. And it sounds different in your head. You will know when you're blocked up, because you will sound different to yourself. Okay, we don't do really oromotor exercises or extensive blowing or sucking exercises to help with nasality. I think sometimes we work on airflow direction, which might be what I call maybe some blowing or sucking exercises, but we're doing it more for them to understand the differences versus improving the function. So a lot of times we do some of those activities to show the difference, like blowing out, blowing in, oral air pressure versus nasal air pressure. But that's not going to improve their speech, how they say a sound. It's more of giving them the awareness of airflow and where it should be directed. So, and Ann Kumar is the one of the greatest therapists on craniofacial. She's part of the craniofacial team at Cincinnati Children's Hospital. She has written several textbooks. She's kind of the guru in that area. So anything by her, you look that up. Her stuff is great. She's also in charge of the speech pathology department at Cincinnati Children's. So good resources. She's one of the most reliable resources when I look stuff up with regards to resonance. Because we don't really, it comes up on occasion. It's not something we do every day all the time. But if you're consistently working with cleft palate and cleft palate repair, craniofacial anomalies, this does usually come up quite a bit for that group. Okay, any other questions? So what to do this week? Okay, now I can hit the next button. So we have a observation, master clinician, a quiz, and the read and review. So this one, what we're looking for, so when we're looking at a client will produce stop consonants. So we give you the stop consonants, P, B, T, and D with appropriate oral airflow. So if you see a goal like that, what we're trying to do is reduce the nasality. So what might we do in a session? Here's your goal. This is what's going to happen. This is more of an applicable of real life therapy. You're gonna read this goal. Johnny's got to work on his consonants. And when you see with appropriate oral airflow, then that gives you the clue that they're producing it with some kinds of nasality, or they're substituting N or M instead of P or B. So there's something going on weird with the nasality if they put in the goal with proper oral airflow. So of course, hopefully your supervisor will be able to explain all that to you, but this is what happens in your day in and day out life as the SLPA. You're gonna read a goal and be like, why did they write it like that? If you see that, because usually we can't really write a goal that they're going to stop the nasalities. You might write a goal, you know, client will reduce nasality by producing stop consonants correctly in whatever criteria. But again, we try to write them in the positive, not what they're not going to do, what they are going to do. So you'll see it. That's why sometimes goals are worded weird. So when in doubt, ask your supervisor. But so that's for the read and review summary. Any other questions? No. Okay, hold on. Let me stop the share. Check the chat. Okay. Alrighty. If no other questions, I appreciate you guys joining me and have a good night.